pleasure to see you.
Dr. McCord, pleasure to see you also.
Thank you. So everyone who's in the room at this particular time, hello for another QA webinar Wednesday. Welcome, welcome, welcome. And I'm going to turn the program initially over to Dr. Schmidt. Dr. Schmidt.
Thank you, Dr. McCord. Well, today we are having the topic of the QA clinical protocol discussion. And what we're going to do in this next hour is to kind of put some of the things we've learned so far in the QA protocol into perspective, or so those of you who are new to QA, to give you an overview and a perspective of what we do in Quintessential Applications. The QA distance learning program is designed to allow for home study of QA by the QA DVDs, professionally recorded DVDs of each of the 15 QA sessions, QA audio CDs, the overview of the thought process behind the technical applications of the course, and the QA book, the QA manual, Quintessential Applications manual that we are most of us familiar with. The QA distance learning program is supported by Wednesday webinars that expand the understanding and concepts and principles taught in the QA course, that enhance the practitioner's ability to use the techniques taught in the QA course, and then provide the opportunity to ask questions directly to myself and Dr. McCord. The QA webinar recordings are now available online. They are 10 QA webinars supporting QA sessions 1 through 3, and 9 QA webinars supporting sessions 4 through 6, another set of 9 supporting QA sessions 7 through 9, and another set of 9 QA webinars supporting sessions 10 through 12. These are available if you go to the website, www.quintessentialapplications.com. These are available for purchase, introductory price of $99 for each set of these. That comes to about $11 a webinar, which is a real steal. Now, what is Quintessential Applications? QA is an open system open to all techniques and procedures past, present, and future. QA uses the manual muscle testing response as a semantic window on neurological function. So we use muscle testing. We come from a background of applied kinesiology. And with AK testing, guided by the wisdom inherent in the QA clinical protocol, we enter the forest of patients' symptoms with a map leading us toward a favorable and sometimes remarkable outcome. Basically, Quintessential Applications is what to do first, next, and last. And the common clinical approach is revised. It is common that most clinicians of most professions, actually, it's the common clinical approach in all healing professions to look at the patient's local complaint as the primary focus of the initial clinical assessment. The QA clinical protocol revises this focus by insightfully approaching the patient's presenting complaints as an integral part of their overall physiology. And that's what we're going to talk about today. We're going to look at the patient in that overall physiology. It assesses and treats physiology gone wrong in a systemically oriented, logical, efficient, and clinically rewarding manner. So what most clinicians in all professions do is start with the patient coming in with a local problem. They look at the local area, and then they focus on that, and then tend to step back and look at more systemic issues secondary to the local problem. What we learn to do and what our QA docs do is we look at systemic issues first, and then we look at the systemic issues and clear the systemic issues which may be contributing to the local problem, and then we'll focus on the local problem after we've cleared the major systemic issues. Having done this, we end up finding that many times the local problems are 70, 80%, 90% better just from addressing the systemic factors. It's like the local problem is almost like the leading edge of the problem. When we fix the systemic issues, we suspend the body's progress in that pathology, and the local problem then, like the parrot in the cave, gets the parakeet in the cave looking for the gases. That local problem is that leading edge of that issue. We fix the systemic problems, and the local problems get much better as well. So what Dr. McCord has said is the order in which you perform your techniques may be more important than the techniques themselves. We all have a bunch of tools, and we've different people in different professions and different trainings and different seminars we all have different tools, but the key to make things happen physiologically is to order the techniques which you perform in the most efficient fashion. What to do first, next, and last. Regardless of our background, regardless of our profession, regardless of our previous training, what happens in QA is whatever anyone's philosophy is. In QA, the philosophy becomes the physiology, and physiology becomes our philosophy. and we follow physiological processes which lead us to reinforce the philosophy of healing and natural healthcare issues that we can address in patients. Quintessential Applications encourages favorable outcomes by addressing systemic phenomena prior to treating local problems. When the QA clinical protocol is followed, the optimal time to employ a specific therapy will be revealed, and the underlying cause will be resolved. So often we see patients who've been everywhere else, someone looking at their local problems, maybe have headaches, and everybody's trying to fix their head or their cranium or their TMJ or their neck. And what we find is we look at these other issues, injuries and systemic nutritional factors first, and we fix those things, and the local problem resolves or becomes very readily resolved when we treat it locally. And this is a big concept of QA, is that our philosophy is the physiology. Our philosophy is our physiology, and our physiology is our philosophy, and we look at things in a physiological manner in a hierarchy of what to do first, next, and last. So the Quintessential Applications course is available for Diplomate Nutrition ACBN credits. The CE hour requirements are approved through the Department of Integrative Medicine of the University of Miami Miller School of Medicine. To get these hours, all QA proficiency requirements must be fulfilled, and the doctor must pass the written examination for Level 1 and Level 2 proficiency, which is now available in the very immediate future online. We'll now be giving the QA Level 1 and Level 2 proficiency tests online. You can achieve 180 hours of ACBN credit by completing the entire 180 hours of the QA course through the DVDs, through distance learning, or for live study at the seminars that we teach. It requires 300 hours to get your ACBN diplomate. Well, the Level 1 and Level 2 proficiency requirements are attendance or verified ownership of the DVDs of QA sessions 1 through 7 for Level 1 and QA sessions 1 through 15, all 15 sessions for Level 2. Verified ownership of the QA book and the QA audio CDs, the thought process behind how we apply the procedures. Level 1 requires the passing of a brief practical exam, including muscle testing and fundamental procedures. Or if you've completed a basic 100-hour course from ICAK, then that can be waived. Or if you've taken an ICAK-approved muscle testing course, our practical exam can be waived. The Level 1 proficiency requirements also require 2 brief case histories, which are what we call IRT stories, injury recall technique stories. They're like a paragraph each. They're what you would tell someone when you're sitting at a break in the seminar. I had a patient who, and you tell the IRT story, you just write that down. And you send the IRT stories to Michelle at aksp@theuplink.com and include a statement of permission to use so we can reproduce those. After all of the requirements are fulfilled, the doctor is eligible to sit for the examination covering sessions 1 through 7 in the QA audio CDs. Level 2 proficiency requirements require 2 additional case reports, a brief, interesting case story, a 1-paragraph story similar to the IRT story, could be another IRT story, and then a longer case history of 1 page following a patient's progress for at least 3 office visits demonstrating the use of the QA clinical protocol. We'll provide you a checklist to fill in for that purpose. We send these also to Michelle at aksp@theuplink.com. After all of the requirements are fulfilled, the doctor is eligible to sit for the written exam covering sessions 1 through 15 in the QA audio CDs. We have one more webinar in January, and it's going to be the QA clinical protocol, and Dr. McCord will be providing an actual demonstration of the protocol, treating a patient on camera. This will be a unique first-time thing for us. Today's QA webinar is a QA clinical protocol discussion, and yet before we get to that, does anyone have any questions or comments or cases to share from QA sessions 1 through 13 or anything else?
There was a comment, and I'll try to get back to it because many people have entered the room since then, regarding a patient with extreme gum disease and a very unusual skin rash. Lab testing revealed a MTHFR ++ genetic SNP, and the lab testing also showed indications of the need for folic acid B12. AK testing revealed 5-MTHF and methyl B12 after 2 weeks on supplementation. Improved gum disease and skin rash has abated. So we see that using manual muscle testing as a window on neurologic function assists us in verifying and or seeing the same thing that we might see on lab work. Wally,
Folic acid.
Go ahead again.
Pardon me?
Say that again. I'm sorry.
That was folic acid, one of my favorite nutrients that we discussed last week.
Yeah, absolutely.
Great comment. Thank you.
Wally, you mentioned if magnesium is needed to check for inflammation when discussing the CAC factors in QA step 12. So how does this cause us to lose our magnesium?
Inflammatory processes cause the body to spill magnesium in the urine, and I think the perspiration as well. The exact mechanism I am not that clear on. That's one of those things that I've heard for so many years I sort of just take as a clinical fact. But basically, when there's inflammatory process, magnesium sort of goes in one ear and out the other, or in one end and out the other. So we have a tendency to have to supplement magnesium in patients who have a great deal of inflammation. The thing is that many doctors use tons of magnesium. We find that we don't have to use quite so much magnesium when we correct the inflammatory factors that are primarily found in the systemic nutritional factors, QA steps 5 through 8, and also QA steps 9 through 11 when we address the immune system. Yes, we still use magnesium, but its need goes down dramatically, and the dose level necessary goes down dramatically. The exact mechanism I can't tell you, but that's a clinical fact that's been known for some time.
Yesterday I had a patient with continuous severe toothaches at the level of the 6 anterior upper and lower teeth for which no cause could be found. The aches started following the resection of a bone tumor in her jaw and partial cheek resection. IRT treatment, especially the scar from a porticat for a Hodgkin lymphoma 20 years ago, resolved her pain completely. For the first time in 4 years, her teeth didn't hurt anymore.
Wow. That's great.
Incredible. These are the kinds of things that we all see, but give us a tremendous appreciation for what the QA clinical protocol offers to all of us, and the possibility of a remarkable outcome instantaneously, in the common vernacular, unexplained. In our vernacular and our understanding of neurologic function, it's very easily explained. I attended the NutriWest Winter Symposium on Inflammation in Phoenix this past weekend. Each and every one of the speakers confirmed to me what Dr. Schmidt and McCord have said for years. You must first control inflammation. Comment, Dr. Schmidt?
I would concur, and it's nice to hear other people think the same way. I would mention, by the way, when we talked about the IRT stories for the QA Level 1 proficiency requirements, what you just read there from Dr. Atwater's, Dr. Atwater's, that is a QA proficiency level 1 qualifying IRT story. And if she would send that to us, we would actually put it in the list and put it on the website with the other IRT stories. That's a great IRT story, and that's basically as simple as we require. But if you would send us to us, Marielle, we will give us permission to use. We'll put it up on the website with the other ones. That's a great story.
Okay, well, nice comments. Thank you very much.
There's another question here. It says from Dr. Roberts, it says, I had tested all immune muscles in the clear and with teeth together with no weaknesses found. It wasn't until I cleared GALT with nutrition, the gut-associated lymphoid tissue with nutrition, that I was able to find the weak immune muscles. Is this because I took it out of order? Have you seen this as well? Well, it is because you took it out of order, and I have seen it, and that's why we put the order the way it is. What happens is sometimes the immune system will be receiving messages from the GI tract that are driving the immune system to hyperfunction to the point where the immune system muscles will not even be normal. They'll actually be so you can't turn them off, like over-facilitated or biased toward facilitation, as we say. And when you clear the gut, then that allows the stress on the thymus or the spleen, for example, to be lowered to the point where you can find that those organs are really being depleted by this stress coming from the gut. You've got to fix the gut before you enter steps 9, 10, 11 and look for the immune system. When you deal with the immune system, if you just check the thymus muscle, the infraspinatus, or the spleen muscle, the middle and lower trapezius, before you do steps 5 and 6 and the other inflammatory processes related in steps 5 and 8, if you check those muscles, sometimes they're not only just strong, you can't turn them off. Then you fix the gut, or whatever other inflammatory processes there are between the first 8 steps, and then you go back and retest those muscles. And many times they're weak in the clear because now they've been exhausted. The thymus may, for example, be exhausted from all that stress of all those inflammatory chemicals driving it coming from the gut. But it doesn't show up. It shows up in hyper mode almost until you clear that gut, and now all of a sudden the thymus says, thank you, but now I need some support myself. Whew, and muscle shows weak. I hope that's an explanation that's clear. The other
I
question.
think that,
Go ahead.
yeah, there are other questions, and I see them too. Let me make another comment about that, Dr. Schmidt. It is important to remember that in steps 9, 10, and 11, after we've identified a weak muscle, addressed systemic nutritional factors following the application of IRT and tapping technique procedures, that the manifestation of immune system muscle weakness occurs in layers as the immune system reveals itself to us, in a sense, through those steps 9, 10, and 11. And that's one of the reasons for the clinical protocol, is because you won't find hidden muscle weaknesses will be revealed. And muscle weaknesses that have been present initially will be resolved by addressing systemic phenomena. So it's just extremely important for us to follow this process and realize that we're going to expose the nervous system and expose that weaknesses that were present are not primary but secondary to other issues, and weaknesses that are unable to be identified will reveal themselves as we clear away the debris, clear away the rust, so that we're not painting over that in any way, shape, or form. Go ahead, Dr. Schmidt.
There's another question. Thank you, Kerry. That made it probably much clearer than I did. Here's a question that says, I have a client with a chronic tonsil infection. Spleen, thymus, and looks like chem points are not sore. Could it be that the body is not recognizing the infection? What would you suggest? I've done IRT to the tonsils already. Okay, that's good. Now what Kerry just said, again, we have to make sure we clear everything in the proper order to make the thymus and spleen show up. However, there are patients whose thymus and spleen, which are really part of the adaptive immune system, are doing okay. But the innate immune system, and we've talked about this in some of the previous webinars, and some of the seminars I've taught, especially the Clinical Pearls Immune System seminar, we emphasize this. The innate immune system is the part of the immune system that's the inborn part of the immune system that recognizes the difference between self and non-self. The innate immune system is in the white blood cells, not in any particular organ. And so we have to make sure we have adequate numbers and the types of white blood cells, which requires, of course, B12 and folic acid, to be able to make sure our white blood cells are carrying the proper messages and are strong enough to carry the proper messages for the innate immune system. It is the innate immune system which then activates the thymus and the spleen activities by recognizing the difference between self and non-self. That is to say, it is the white blood cells that recognize the non-self and then start a reaction to it, which then involves the Th1 and the Th2 pathway, which are part of what's called the adaptive immune system, which then triggers the adaptive immune system, which then implicates the thymus and the spleen and the rest of the immune system in the body. So it's possible you might not find a thymus or a spleen issue. However, there is still an immune system problem, and you would then test nutrients which were associated with the immune system. For example, vitamin C is a very powerful innate immune system stimulator, and other substances which might be helpful for immune system function.
The other thing that might be considered is that any time you have a chronic problem, infection or otherwise, there is always some underlying driver of that issue, and that underlying driver, of course, could be found in systemic nutritional factors, the histamine response. And by repeating some of what Dr. Schmidt says, please forgive me, but the allergy and heavy metal toxicity are often in the underlying issues associated with any chronic problem. The other thing that could be at issue is sometimes infections are cytokine driven, and cytokine detoxification in the liver may have to be looked at as well. So all of these things are embedded within the QA clinical protocol and reveal themselves in an ordered fashion. So it's so important, if we can, to know when we've skipped a step, because we all do. We all enter that forest of the patient's symptoms, and we go through this step-by-step process, but we skip steps. And knowing that we have assists us in going back and addressing those issues that we might have failed to address initially. But this ordered process allows us to encourage that favorable outcome more frequently.
Looks like there's one more question. Thank you, Kerry. If a patient complains of GI-related symptoms, would you always work through every step of the protocol in the proper given order, in the order given, Or would you, for instance, address injuries, EFAs, allergies, and then skip straight to systemic GI and then local problems? Well, if you think in terms of the way the protocol is set up, yes, we do injuries first in step 4. Step 5 and step 6, step 5 relating to essential fatty acids and step 6 relating to allergies, are virtually always going to implicate the digestive system. And so what I would tell you is do step 5 and do step 6 and rule those major factors of the intestinal function and the GI tract function out during steps 5 and 6. If the patient has significant GI tract issues, they may also want to go to steps 9, 10, and 11, because oftentimes there are systemic immune system issues which are driving the gut immune system, just like we talked about a few minutes ago and said the gut immune system can drive the systemic immune system, the thymus and spleen. Well, the thymus and spleen can be weak and affect the gut immune system as well. So we do that steps 9, 10, and 11. And then at that point, if you've got these major GI complaints, I would go ahead. You could skip ahead, and you can skip ahead to the steps 21 through 23. For example, many times I see the gastrocolic reflex as an issue from something the patient ate fairly recently, and I'll have to skip ahead to that to clear out that gastrocolic reflex because they've got a raging open ileocecal valve that they present with because maybe last night they went out and had spicy food, and that's caused a gastrocolic reflex or something, and so I can move that up in the protocol. But then you must go back and pick up where you left off at steps 12 and 13, because when we get to step 13 in heart-focused activity, the heart-focused activity does have a very powerful effect on the GI tract as well. So, yes, it's okay to go ahead and skip ahead, and it makes a lot of sense sometimes if that's where the patient's issues are in the GI tract. But still, check steps 4, 5, and 6 for sure, and then 9 through 11 for sure, and then you can go on and go down to 21, 23. Then come back up to step 12 and pick up where you left off in the process of treating the patient, either that day or the next appointment or whatever. But that's a reasonably common complaint that we see where patients come in, and we do have to skip around just a little bit. But that's why the protocol is what it is. It gives you the map. You can take a side trip, but it always gives you the map to come back to get you on the main highway to the patient's health.
One more comment. I'm going to abbreviate this comment and question so that you can respond to it. There doesn't seem to be any method and protocol for determining how much of a supplement to take or how long to take it.
My experience is that there are a lot of different people who have techniques of deciding the dosage. I've used my clinical judgment for many years. That seems to work better than any other technique I've seen. You can use a good technique if you develop one on how to determine dose during the protocol. But I'll tell you that if you look at the body and consider that the recommended daily allowance or the daily value is determined to keep a person even, Steven. If everything's fine, then just keeps them even for what they have, their basic daily needs. But if they're sick, they may need up to 10 times that RDA amount. So if a person has had an organ reserve of maybe 4 to 10 times, every organ has really a 4 to 10-fold organ reserve, then if you got the organ under stress, you may want to go 4 to 10 times the RDA of nutritional support just to keep that patient's nutritional intake up with the demands for that stress that they're under. And so that's how I determine, based on the level of the patient's symptoms, the chronicity of their potential dietary problems, I will use anywhere from the daily value or the RDA amount of a nutrient up to 10 times the RDA to supply nutritional support. You can go higher, but once you go more than 10 times the RDA, let's say if you go 20 times the RDA or 20 times the daily value or higher, now you're into using that nutritional substance almost as a pharmaceutical, trying to, rather than potentially give the body the nutrient it needs for some pathway, you're giving the body a driving force, such as giving ascorbic acid to make acidity, for example, and that's making it more of a pharmaceutical, or actually a nutraceutical, than it is a simple nutrient effect that it has throughout the body. So that's kind of a little bit of an involved answer, but that's basically how I've learned to do it through the years, is use clinical judgment. Based on the next time the patient comes in, retest the nutrient. If they're still strengthening on it, raise the dose. If they're not strengthening on it, leave them on it because they probably still need it. And then again, you have to use clinical judgment and physiological knowledge. Know that, for example, it takes 4 months for all the red blood cells to be reproduced. So you want to give B12, folic acid, iron, and so on for a full 4 months on a patient so that every red blood cell that's produced during the next 4 months has an adequate supply of those nutrients to build them fully. And similarly, if you have patients who are very B vitamin deficient, it showed, for example, in studies that it takes up to 9 months to completely replenish B vitamins when patients start with a complete depletion of B vitamins. So these kind of physiological facts help us determine length of time as well.
And part of that discussion is intimated and reviewed at the bottom left-hand page of tab number 8B in the second edition of the QA book. That's a call-out box on the left-hand page at the bottom of the page for those of you who are interested. It looks like we got the comments and questions out of the way in the front half, and depending on how long I speak, we may not have a back half to do any more questions, but we'll see.
Okay, well, Carrie, I'm going to hand it over to you. I'm going to hide myself and wish you well. And Carrie, take over, and I will see you all later.
Thank you, Dr. Schmidt. What is Quintessential Applications? Well, Quintessential Applications is a physiologically based, basic science-driven neurological hierarchy for the ordered application of clinical procedures and techniques. What does that mean? Well, Dr. Schmidt says our physiology becomes our philosophy, and our philosophy becomes our physiology. That physiology and the understanding of physiology really drives our understanding of how to apply these particular techniques in the light of basic sciences of neurology and biochemistry. And then we develop a hierarchy for the ordered application of these clinical procedures. That's applied quintessential applications. Quintessential, the reason we chose this, it means ideal or standard. So this is the standard application. And what kind of application? Systems first, local second, ordered according to a neurological and a biochemical hierarchy. So QA is an open system. It has its origins in applied kinesiology. It uses the manual muscle testing response as a window on neurological function. It's for all doctors interested in functional medicine, novice and experienced, and requires no prior training in manual muscle testing or AK because we use a comprehensive approach in teaching it. Now, we're going to review some things that all of us know. We're also going to look at the physiologic effects of the Quintessential Applications clinical protocol. I'm going to review a couple of case histories, and then I'm going to prepare us for the demonstration that will happen next week. So the most elegant use of the manual muscle test and response, we say, is a systematic window on neurological function, an extension of the neurological exam. Why do we say that? Well, we have autonomic windows on neurological function. All of us use these autonomic windows. We take pulse and respiration. We take blood pressure. We look at pupil light reflexes. In essence, aren't these truly muscle tests? Maybe smooth muscle tests, but aren't they muscle tests? Yes, they are. So muscle testing is an important tool in the decision-making process of what to do for a patient when confronted with a number of different alternatives. Dr. Schmidt has said that. So what is our simplified orientation in the QA clinical protocol that really comes from our roots in Dr. Goodhart's mantra of measure, 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 measure something besides muscle testing? We find an indicator of dysfunction. We find pain, range of motion, 1 foot standing, a Romberg's test that's off, whatever the case might be. We identify then an inhibited or weak muscle using manual muscle testing. And then we use sensory challenges. What kind of challenges? We taste a substance. We have the patient touch a particular area. We rub, we pinch. We do something to evaluate or to stimulate an incoming sensory pathway. And then we observe a manual muscle testing outcome to identify the most appropriate therapy. That's what AK is all about. Then we perform the therapy identified, recheck both the indicator of dysfunction and the weak muscle. So in the outline, the summary in the QA manual that's in the first part of the manual, in the first paragraph, or maybe the second paragraph, can't remember, I think it's the first paragraph, of the summary of the paper that Dr. Schmidt wrote, a neurological rationale, or the neurological rationale, for a comprehensive clinical protocol using applied kinesiology techniques. It says, the QA clinical protocol, or AK, utilizes the manual muscle testing response. That's inhibited, a weak muscle, facilitated, a strong muscle, or over-facilitated, but in the parlance of neurology, maybe that's more like bias towards facilitation, what we call a hyperactive response, a muscle that can't be inhibited by autogenic inhibition. So a muscle testing response as a reflection of the status of the anterior horn motor neuron pool for the muscle being tested. So we use these sensory receptor-based diagnostic challenges, touching, rubbing, pinching, etc. And these challenges result in muscle testing outcomes. In other words, they result with these sensory inputs, changes in the anterior horn motor neuron pool for the muscle that we're testing, or for the muscles that we're testing, that are then used to direct appropriate therapy. So when somebody says, what are you doing? Well, I'm testing muscles, if they get weak, if they get strong. Well, that's appropriate to identify weak and strong, but actually we're testing the response of that particular anterior horn motor neuron pool to stimulation, and it shows up in a muscle testing response. So that's the neurological explanation. The evolution of quintessential applications has really occurred over more than a 30-year time of focused attention by Dr. Schmidt to determine what to do first, next, and last, both by clinical trial as well as by observation of the basic sciences of biochemistry and neurology. This whole curriculum and this whole orientation, philosophically and physiologically, is based on a peer-reviewed referenced article by Dr. Schmidt and Dr. Yannick published in 1999, Expanding the Neurological Examination Using Functional Neurologic Assessment, Part 2, the Neurologic Basis of Applied Kinesiology. QA suggests, as you know, that we address systemic phenomena prior to treating local problems, which encourages favorable outcomes. So most clinicians, all professions, address local issues first and then systemic issues. But as Dr. Schmidt said, it's the common clinical approach to address these local issues first as the primary focus of our initial clinical assessment. But the QA clinical protocol revises our focus by insightfully approaching the patients presenting complaints as an integral part of their overall physiology. It assesses and treats physiology gone wrong in a systemically oriented, logical, efficient, and often clinically rewarding manner. So QA docs address systemic influences prior to treating local problems. So, with all that out of the way, examples of the physiologic thought processes that underlie the QA clinical protocol. Now, this is what we all do, but think about this. And these are the things that a few of the hundreds of things that Dr. Schmidt thought about in putting this process together. Since all systems, immune, endocrine, gut, muscular, etc., are adversely impacted by nociception, shouldn't we address nociceptive activity prior to addressing any other symptom or system, any other system or local problem? Well, we remember that nociception has 3 pre-programmed responses in the spinal cord: a muscle withdrawal response, or a flexor reflex afferent response, an autonomic response, that's local intermediolateral cell column response, and a systemic autonomic response as well. The local response, we remember, is turning off the blood supply. Part of that local response, turning off the blood supply to the area so that if you're bleeding internally or externally, that the ability to bleed to death gets reduced, which is a good thing. And then communication with higher centers, both location, quality, and memory of the injury and the pain and the dysfunction, as well as communication to the limbic system to create that emotional response that we call pain. There's also an endocrine response via the hypothalamic pituitary adrenal axis. So as the incoming nociception rises on pathways that go up the anterolateral spinal tracts, we have a spinothalamic tract that then goes to the hypothalamus. And the hypothalamus creates downgoing responses into the reticulospinal tracts that pass through the anterior horn motor neurons of the muscles that we test, as well as biochemistry imbalances, as well as the impact of nociception on the cerebellum and then into the cortex through the mesencephalic regions of the red nucleus. So we have autonomic responses both driven by the cerebellum and driven by the mesencephalon that occur due to incoming unbridled nociception. As you can see from this monograph, which is on the left-hand page of QA Step 4A, there are 3 interneurons in the cord that nociception stimulates. 1, stimulating those anterior spinal tracts going to higher centers. 2, stimulating the alpha motor neuron for flexor withdrawal response, the withdrawal response from the area of injury. And what I tell patients is, if you have this withdrawal response from the area of injury and it's persistent and habituated, it's a habit pattern, no matter what I do structurally, you're going to just unwind and come back to this habitual pattern of muscle withdrawal. So we're going to relieve that first. And the third thing in this inner neuron on the right-hand side of the slide, it goes to the autonomic ganglion, and this is the motor neurons in the intermediolateral cell column, which affect local autonomic expression. So, since the immune system is impacted by cytokines, little inflammatory chemicals, arising from irritation in the GI tract, shouldn't we address GI tract irritants, for example, allergens, bad fats, prior to addressing systemic immune system function? This process of the clinical protocol is not put together haphazardly. It's put together making physiologic sense in relationship to how we should address the human system. Since cortisol inhibits the immune system, it suppresses immune system function, shouldn't we address low immune system function prior to improving adrenal activity? So again, part of this physiologic thought process. Since the citric acid cycle is inhibited by immune system activity, shouldn't we address immune system function prior to adding B vitamins and manganese to improve the activity in the citric acid cycle? And since the adrenal glands mobilize glucose for ATP production, shouldn't we address the citric acid cycle prior to treating the adrenals? And since all visceral and biochemical imbalances are reflected in and create muscle imbalances, yes, you heard me correctly. Since all visceral and biochemical imbalances are reflected in and create muscle imbalances, shouldn't we address all systemic issues prior to making musculoskeletal and spinal adjustments? Now, many of us are chiropractors. Many of us base our work on structural activity. But since all visceral and biochemical imbalances are reflected in and create muscle imbalances, that musculoskeletal and spinal mechanics are compromised by these influences. So shouldn't we address these systemic influences prior to addressing the structural effects? Yes. The answer to all of these questions is yes. QA considers hundreds of similar physiological principles and focuses our attention on efficiently achieving a desired outcome by not skipping over systemic influences that might be present. So what can QA do for you and your patients? If it walks into your office, QA addresses it. Essentially, 90% of all the things that we see, QA addresses. So here's a simplified outline of what appears in the QA book called the QA Clinical Protocol. Now, these beginning procedures, we address pain and injuries, but what are we really doing? If you read that summary of the neurological rationale for a comprehensive clinical protocol using applied kinesiology techniques, the paper that Dr. Schmidt wrote in 2005 discussing the thought process that drives the QA Clinical Protocol application, it will say in that summary that our purpose is to reduce cortical and cerebellar asymmetries, that we're reducing asymmetries in higher centers and restoring normal muscle spindle cell control mechanisms necessary for muscular and postural control. That's what we're doing. Some who have been introduced to IRT and tapping techniques think we're trying to strengthen a weak muscle. Well, sometimes the weak muscle does strengthen. Sometimes it doesn't. That's not the point. The point is to restore the mechanisms that make the muscles operate appropriately. So the anterior horn motor neuron pool, it has influence from the top down, the bottom up, and at local areas that collectively are called the central integrated state of that anterior horn motor neuron pool. So if we have more inhibition coming in or more facilitation coming in, that's going to dictate the relative response to manual muscle testing. But what we're trying to do with these techniques, injury recall techniques, tapping techniques, is reduce cortical and or cerebellar asymmetries. which means if there's asymmetric, we heard Dr. Schmidt talk about, there's asymmetric input in the cortical and cerebellar into the cerebellum, and thereby affecting the cortex and the middle brain, the mesencephalon, you're going to have imbalances of output, both autonomic and structural and otherwise. And that creates this imbalance, begets more imbalance. So what we want to do is restore that function, reduce cortical and or cerebellar asymmetries, restore normal muscle spindle cell control mechanisms necessary for muscular and postural control. Autogenic facilitation, the stretching of the muscle spindle cell, should respond just like striking a reflex on a knee or on an arm. That reflex should cause that muscle to respond. That's a monosynaptic reflex to the cord. It's the most powerful, arguably the most powerful reflex in the body, and yet it is overridden by nociception. So then systemic nutritional factors. What are they? They're factors that affect nerve, brain, immune function, again, from this summary of the neurological rationale. They affect nerve, brain, and immune function, inflammation, energy production, tissue oxygen supply, cartilage and connective tissue repair. And then systemic structural factors, which are the TMJ and cranial faults. We've noted in applied kinesiology the profound impact of treating the TMJ and cranium. And we've explained it in many ways, from the impact on the cerebral spinal fluid flow to other structural phenomena. We've observed it. But what creates it is that oftentimes, because the cranium and TMJ have their impact through nociceptive activity from the sutures and trigeminal nerve from the face, the jaw, etc., all of those things impact the trigeminal nerve has its cell body in the mesencephalon. The mesencephalic nucleus of 5. It has its descending nucleus that descends all the way, it's called the spinal nucleus, descends all the way into the cervical spine, sometimes down as far as the 5th cervical segment. So these systemic structural factors, what we found, are often secondary to immune system dysfunction, impacting the mesencephalic reticular formation and affecting, among other things, TMJ muscle dysfunction, pattern generation, the patterns of muscular activity, and autonomic expression. So then we address other systemic factors like endocrine effects and GI tract and emotional stress prior to treating local problems. So this is the QA clinical protocol in the brilliance of its manifestation. I keep telling Dr. Schmidt that the most profound thing that he has provided for us, besides all the wonderful tools that we use in the office, the most profound thing that has been provided is a thought process that organizes our clinical thinking in a matrix that allows us to know what to do first, next, and last, and anything that we use, where to place it according to this hierarchy. So let's talk about a couple of cases. I had a 64-year-old female that entered my office diagnosed with severe depression and fibromyalgia. That was the diagnosis. She was in bed most of the day. She cried for 6 to 8 hours daily for months. Her depression had begun 10 years prior. She had pain, pins and needles from elbows to hands and knees to feet for 5 years. Now, that's what they diagnosed as fibromyalgia. You and I probably would have questioned that. She had been medically detoxed 2 months prior from narcotic medications, and she was scheduled for electroshock therapy, the typical patient that walks into the office. Her psychologist brother-in-law from Oklahoma, she was from Georgia, Atlanta, Georgia, referred her to me and said, before you go to electroshock therapy, see what Dr. McCord can do with quintessential applications. Well, so what did we do? Well, in steps numbers 1 through 4, we identified areas of imbalance. We looked at range of motion. We looked at discomfort. We had her rated on a scale of 0 to 10. And then we addressed sources of incoming nociception adversely affecting the cerebellum and cortex. These were reduced. That's what we did. Now, you could say, well, we did IRT and we did tapping techniques, but what did we do physiologically? The sources of incoming nociception adversely affecting the cerebellum and the cortex were reduced. Then we addressed systemic nutritional factors, and sources of inflammation were identified. Dietary recommendations were made, and the adverse effects of histamine on the brain. Histamine is an excitatory neurotransmitter. On the adrenal glands, some say it's the most powerful irritant to the adrenal. And on immune system function, suppressing immune system function or aggravating immune system function, that was relieved. Now, how do we relieve that? In doing the techniques that we do, we impact in the moment the irritation to the nervous system that allows us, and the biochemistry that allows us to see the kind of clinical responses initially and immediately that we do see, besides telling people to stay away from the offenders. And then lowered immune function was addressed. So steps 9, 10, 11 I'm in now, right? So I was in steps 5 through 6 in that middle statement. We identified areas of inflammation. We made dietary recommendations. We redressed the adverse effects of histamine on the brain, the adrenals, and the immune function. And then, because we had lowered immune activity, we addressed that by redressing the potentially aggravating influence on the mesolimbic pathway that may drive or at best complicate depression. So Dr. Schmidt talks about this, and we talk about it in the QA course, that the mesolimbic pathway, the mesencephalon, affects the limbic system, and they drive, an imbalanced mesencephalon drives the limbic pathway to pain and pleasure, whether that's emotional or physiological. And so sometimes depression or anxiety are driven by immune system dysfunction, and when we treat the immune system and relieve, after we've treated sources of incoming nociception, and relieve the impact of this imbalance in the mesencephalon, we relieve those mesolimbic pathways and thereby relieve the influences on the depression, if not that which drives it totally, that which complicates it. So that's what we did physiologically. So what were the results? Well, I treated that patient 2 days in a row, and after the first day, she already felt that her fibromyalgic issues were 75% reduced. By the next day, her depression and fibromyalgia had disappeared. She asked to drive home. Her husband was shocked. And 1.5 years later, in a phone conversation with the patient, there had been no recurrence of clinical depression or exacerbation of extremity pain, pins and needles. So that was just, the first day was just the first 11 steps, and after that we kind of shored up the edges and provided, of course, nutritional support to assist in the process of her healing. So the application of the QA clinical protocol and encouraged improvement where? In cortical, cerebellar, and mesencephalic function, resulting in a remarkable and lasting response. Well, here's another one. 50-plus-year-old doctor of chiropractic complained of back, hip, and knee pain. He was unable to walk without canes. Now, why was that? And he was only able to walk with canes for a couple of steps because he had an invaginated acetabulum. Now, what that means is, and I've never seen one of these, I've just read about them, is that the head of the femur went right through the acetabulum, the socket, and invaginated it. Now, he needs an operation. He's wheelchair bound. But since he was wheelchair bound, he was a big guy to begin with, he gained over 100 pounds. He probably weighed close to 400 pounds at the time. So he was in a class that Dr. Schmidt and I were teaching at the Florida Chiropractic Association National Convention in August of 2010. And during the middle of that class, we did a 20-minute workshop. Now, both the doctor that was in the chair as well as his colleague were AK-trained docs, but they had not known anything about the tapping techniques that we were teaching during that session, or the testing for nutrients using the tapping techniques indicators to see if the nutrients relieved the weakening response from using set point technique or NSB technique. And I think this was in a chronic pain workshop, so he was probably using set point technique and maybe LQM. And he tested for nutrients, measuring clinical responses to the tasting of nutrients. So they just tasted the nutrients. Of course, the AK docs tested muscles, but they also, more importantly, test these physiologic indicators. So they tested pain and range of motion. Now, I'll tell you that the clinical response shocked both Dr. Schmidt and myself, and we've seen some wonderful things. But the pain in his back, hip, and knee disappeared. That wasn't so shocking. We see that all the time. But the doctor arose from his wheelchair and walked irregularly because of the invaginated acetabulum without pain and no canes for the first time in 3 years. 2 days later, we were at a 3-day seminar. The treating doctor reported that the pain had not recurred in this patient, and it was the most profound thing he'd ever seen in his clinical practice, and he'd been practicing applied kinesiology since the early 1980s. So, the next webinar, what we're going to try to do is maybe not have that kind of dramatic response, but we're going to go through a QA clinical protocol demonstration. So who's going to be our patient? It's going to be a 28-year-old chiropractic physician who is AK trained and is currently studying Quintessential Application. He had a left shoulder injury 2 months ago, a collision with another playing flag football. That'll teach you to play flag football. Right knee pain, especially at the end of a long day, from a childhood rope swing injury that was surgically repaired 10 years after the injury. A left groin pain from an athletic injury 3 years prior. He was struck in a cup he was wearing over his testicular and private areas. The cup has an edge on it for those of you who haven't been privileged to wear one, and it jammed into the pubic bone and created significant pain that subsequently caused pain in the left testicle that had been treated by tapping techniques and relieved the left testicular pain, but the left groin pain persists. He also has complaints of fatigue, especially during the middle and at the end of the day. So hopefully we won't have too many glitches technologically. We're going to try to preempt those by getting that set up in advance and trying to clear up as many issues as we possibly can. But this is going to be the first time that we've tried to do this live internationally, and I will be treating that patient in my office, so you'll see my testing materials on my wall and my table in front of you and so on. So I tried to talk quickly so we'd have a few minutes at the end. Any chance of having a QA online message board? Is there one already? No, there isn't one already, but it's a good idea. And if you could write that recommendation to Dr. Schmidt or myself at qapplications@aol.com, and you would like to be in charge of it, we can discuss the appropriate applications of its implementation through the website. It's just Dr. Schmidt's, and my time is, as all of you, is appropriately dispersed. So let me make a couple of announcements while you're writing questions on the question board. To order the QA Session 14 DVDs, go to quintessentialapplications.com. Use the exit button to take you there at the end of the seminar. QA webinar recordings available online. Let's go back to the home page and see. Dr. Schmidt, you're still here.
For a moment.
For a moment. So here we are at the home page, and we have the pleasure of having Dr. Schmidt here. Wally, last session you mentioned you have 9 brands of MTHF that you tested. Which brands do you recommend, or how many of the 9 should we have on hand?
I think you need at least 3 brands. Some of them are very similar. They test similarly. We really don't have time to get into that discussion. The first one that came to the United States was FoloPro by Metagenics. The second one was 5-MTHF by Thorne. Now a number of other companies have these products. There's one by Numedica called methylfolate. There's some by Prothera called L-methylfolate and active B12 folate that have the two together. Biotics has recently come out with a methylfolate plus. There actually are 3 prescription items that have 5-methyltetrahydrofolate in them now. One's called Deplin. That's the most well-known. I have all of those, actually, and a few more that I'm not thinking of at the moment. But get at least 3 different kinds, because what I've learned is that when we used the FoloPro for a number of years, and then we started testing with the 5-MTHF by Thorne, the next one that came out, we added about 20% more people who needed that activated folic acid we hadn't found because of, who knows, the processing, the excipients, whatever. And then when we got these other ones, then we've had about another 20% more of patients, 20% to the original group. So we've expanded that original group by 40% greater than it was originally by testing the different companies' versions. And just at least have, I'd say, 3. If you have any doubt, then check the second and the third one. But that's about the best I can tell you. More and more companies are coming out with that all the time.
With the 64-year-old woman that you mentioned, Dr. McCord, do you recall how much time you spent with her? In fact, there's a YouTube video of me talking for about 6 or 7 minutes about this particular thing, which you can YouTube, just put in my name or Quintessential Applications, and you'll find it there. But I spent 2.5 hours the first day. That was consultation, examination,
It's
and
10
treatment,
o'clock.
and then an hour and a half the second day. And at the end of the second day, remarkable outcome, remarkable the end of the first day, but by the end of the second day, as we said, all of those symptoms had disappeared. Well, this has been an interesting discussion. I hope that all of you have gleaned some of the power that is latent within the QA clinical protocol and this physiological thought process that Dr. Schmidt has created for us over a 30 years of focused attention, collaborating with a number of folks in the process of feathering out, if you will, this clinical thought process. Dr. Schmidt has a cab waiting. I wanted to say the last few words before we sign off. Dr. Schmidt.
Thank you for your cogent and comprehensive discussion, Kerry. That was excellent. I really enjoyed listening to it, and I hope everyone else will be here next week to watch you give the demonstration. I look forward to seeing the people in Brussels, as I say, and Kerry said I'm on my way there right now, so I'm going to sign off and wish you well and see you soon.
Thank you, Dr. Schmidt. Everybody, we'll see you next week. Take care.